Yeah, I thank you for the opportunity. My abstract for today is adding bevacizumab to erlotinib as a first-line treatment in advanced EGFR mutant NSCLC. This is a follow-up results of the randomized phase 2 JO25567 study. To give a brief introduction, TKIs in EGFR mutated lung cancer have shown improvement in progression-free survival over chemotherapy, but ultimately they develop resistance and relapse. This has been the major problem. So bevacizumab has shown improvement in drug delivery through multiple hypothetical mechanisms, which includes normalizing the tumor vascular permeability. So it was an idea to compare O25567 compared erlotinib with erlotinib and bevacizumab. And the primary analysis showed that there was a significant PFS benefit with the addition of bevacizumab to erlotinib, but the OS data was not mature. So this study is shows updated PFS and final OS data, which is being presented. So it's a phase 2 study which examined the addition of bevacizumab to erlotinib in the first line, and these were non-squamous NSCLC patients, and these patients were randomized to erlotinib 50 mg versus erlotinib plus bevacizumab 15 mg per kg given every 3 weekly till progression. And point to be noted, it's a phase 2 study and the primary endpoint was progression-free survival. OS was calculated as a post-hoc analysis. Coming to the results, 154 patients, these are randomized to erlotinib bev 75 and erlotinib number 77. The median PFS was better on combination of bevacizumab and erlotinib. It was 16.4 months versus 9.8 months in erlotinib alone. But the final OS was not different between the two arms. So the addition of bevacizumab did not have an overall survival, but it did have an improvement in progression-free survival. So this is the first graph showing improvement in progression-free survival. So initially, the addition of bevacizumab showed an improvement in progression-free survival. It was 16 months versus 9 months, but this was the primary endpoint. But in the overall survival, it was all equal. On the subgroup analysis, the exon 19 and exon 21, that is exon 19 deletion, it was similar. There was no significant differences between the two arms, and so was L858R. The bevacizumab did not have a difference in overall survival. So coming to the safety, bevacizumab is a drug which we have a long experience. The adverse events were similar between the two arms, except that hypertension was higher in the bevacizumab erlo arm. So to conclude, so addition of bevacizumab to erlotinib significantly improved PFS but not overall survival, but the study was powered for PFS and OS was a post-hoc analysis. The authors comment that there are a lot of misses in the follow-up, and the addition of second-line therapy, third-line therapy did make an impact. But having said that, there is a phase 3 trial, NEJ026, that also did not show any improvement in overall survival, the addition of bevacizumab to erlotinib. So my take is that I wouldn't consider routinely adding bevacizumab for all EGFR mutant patients in the first line because of PFS advantage, but rather discuss other options like osimertinib, dacometinib, or even TKI plus chemotherapy. Thank you.